I've worked in psychiatric care for over 2 decades. State hospitals, locked wards, acute units. Most cases blur together, but some linger, defying explanation. My name is Dr. Evelyn Hart, and this is the story of Mr. Ellis, a patient who left me questioning everything. Mr. Ellis arrived at our long-term ward in his late 50s, a history of trauma and selective mutism since his 30s. No family under conservatorship, he was housed in room 204, a quiet corner of our 1960s-era facility. The room had faded linoleum, a high window, and those old acoustic ceiling tiles, details that became significant later. He was nonverbal, alert, and cooperative, nodding or shaking his head during wellness checks. For 9 months, he was silent, his blank stare meeting our efforts to connect. Then, one Tuesday morning, I heard a voice while passing his door. I assumed it was a staff member, but inside, Mr. Ellis sat alone, hands clasped, speaking clearly to a ceiling tile above his bed. His tone was calm, conversational, as if replying to someone unseen, pausing for responses. I asked if he was okay. He didn't acknowledge me, his gaze fixed upward. If I spoke too loudly, he'd stop, retreating into silence for hours. This became a daily ritual. Every morning, same time, same tile. We ruled out seizures, hallucinations, or medication changes. His labs were normal, imaging clear. We hypothesized a dissociative episode, but no trigger emerged. Then, during a routine ceiling inspection for a leak, maintenance removed that tile. Taped to its backside was a faded Polaroid, dated August 3rd, 1978, showing a young woman in the hospital garb, her expression vacant. In the background, a restraint chair was faintly visible. Older staff recognized her, a patient who died in room 204 decades earlier, after a restraint incident during a psychotic episode. She'd suffocated, a tragedy that reshaped protocols. No one knew how the photo got there. The tile hadn't been touched since a 1990s renovation. After the tile's removal, Mr. Ellis stopped speaking entirely, even to the ceiling. He passed quietly in his sleep 2 months later. No distress, just gone. We kept a copy of the Polaroid, not for answers, but because some things demand remembering. Room 204 was stripped bare, the tiles replaced, but its weight remained. In psych, you learn to hold space for the unexplainable. Silence isn't empty. It carries echoes. Mr. Ellis's case wasn't about ghosts, not exactly, but about something lingering. A conversation only he could hear. I left that ward soon after, but when people ask if I believe in the unseen, I think of him, speaking to a ceiling tile, and wonder who was listening. I'm Nurse Laura Bennett, with 20 years in psychiatric care. Acute wards, state facilities, you name it. You learn the rhythm of suffering, the silences, the outbursts, the weight of unspoken pain. But some cases defy every clinical lens. Patient J, dubbed the Night Screamer, was one of those. He arrived just before winter, transferred from an upstate facility. Early 30s, male, diagnosed with treatment-resistant schizophrenia, selectively mute since his teens. No family, no verified history, just hints of psychological mutism as a shield. His intake was routine. Normal vitals, clean labs, no signs of distress. We placed him in room 7B, a single near the nurses' station in our aging hospital wing. For 2 nights, he was unremarkable, silent, compliant, distant. On the 3rd night, at precisely 3:03 a.m., alarms blared. His biometric monitor showed a heart rate spiking past 170 beats per minute, blood pressure surging like he was sprinting. I rushed to his room, expecting a seizure. He was asleep, deeply, no movement, chest rising evenly. The camera confirmed it. No thrashing, no signs of distress. But as I opened the door, a scream hit me. Raw, guttural, not from pain, but something deeper, sourceless. It stopped when I stepped inside. This happened nightly, always at 3:03 a.m. The scream was real. We all heard it. Different shifts, different staff. Yet, audio monitors outside his door recorded nothing. His vitals spiked consistently, but he never stirred. We tried sleep studies. A neurologist noted odd micro-seizures, activity bouncing between brain hemispheres, but no typical signs of night terrors. Medications, lorazepam, trazodone, did nothing. Some staff refused 7B duty, reporting migraines or a strange pull toward his room during the screams. One night, I sat with him before lights out, speaking softly about the weather, a book, anything to connect. He lay still, eyes half open, breathing slowing. That night, 3:03 a.m., passed silently. No scream, no spike. It was a fluke. The next night, the scream returned, louder, and the walls vibrated briefly. 4 seconds, maybe 5. No mechanical cause, no footage showed it, but we all felt it. By week 7, a research clinic requested his transfer. The night before he left, I sat with him again. At 3:03 a.m., he opened his eyes. No scream, just a stare. In a cracked whisper, he said, "It's not me." The only words he ever spoke. He was gone the next day. I traced the transfer, but the clinic had no record of him. In psych, you learn to separate symptoms from something else. Was it delusion? Coincidence? Or was that scream something channeled through him, not from him? I've seen riots, suicide watches, every kind of crisis. But this case makes me wonder whose voice we heard. I'm Dr. Sarah Coleman, a psychiatrist with 18 years in the field. Midwest long-term facilities, locked units, trauma cases. You learn to parse delusions from reality, but some patients blur that line. Clara, as we called her, was one who left us questioning. Clara, mid-40s, arrived at our facility after multiple failed placements. Diagnosed with schizoaffective disorder, she'd been in care since her 20s. No violence, no outbursts, just a quiet precision that unsettled us. She took her lithium and quetiapine, attended therapy, kept to herself. But her presence felt heavy, like she carried something unspoken. We housed her in a single room, 8C, in our aging ward, where peeling paint hinted at the building's 1960s roots. Her behavior was unremarkable until new nurses joined the night shift. Clara would approach them, always alone in the hallway or day room, lock eyes and whisper, "She knows what you did." No malice, just a calm delivery, like passing a note. It became a unit legend. We chalked it up to her disorder, scripting perhaps, or projected paranoia. Seasoned staff shrugged it off, but new nurses felt it differently. Then came Rachel, a travel nurse from Ohio, experienced in psych. On her second night, Clara whispered the phrase. Rachel laughed it off, but by morning, she was shaken, resigning her contract. In the break room, she confessed, 5 years prior in Cleveland, a patient died under her watch during a restraint mishap. A hushed lawsuit followed. She'd buried it, changed agencies. No one here knew. Clara's words hit too close. She left that day. I reviewed Clara's chart, searching for patterns, delusions of guilt, trauma responses, anything. Nothing. No record of the phrase before her arrival. It started weeks in, after a nurse named Karen quit abruptly. Over 2 years, 3 more travel nurses left, each after Clara's whisper. One cited feeling unsafe, another gave no reason. Always new nurses, never techs or permanent staff. When questioned, Clara said, "I just passed the message," deflecting with eerie calm. We adjusted her meds, no change. Therapy yielded nothing. She remained compliant, even kind, but the whispers persisted. I started noting the incidents unofficially, looking for clinical answers. Was she reading micro-expressions? Echoing overheard phrases? The security footage showed no access to staff records, no nighttime wanderings. Yet, each nurse she targeted carried a hidden past, griefs or guilts they'd never shared. One night, I sat with Clara in her room, asking about the whispers. Her eyes met mine, steady, and she said, "Some things don't sleep. They wait for you to listen." No elaboration, just that. I didn't push. Her file stayed clean. No hallucinations, no cognitive decline. Too lucid, if anything. Clara was discharged suddenly, transferred to a private facility upstate. The paperwork was sloppy, signatures off, but she was gone. We never saw her again. In Psych, you learn to hold space for the unexplainable. Was Clara intuitive, or something else? I don't know. But her whispers linger, like a message from somewhere beyond our charts. I'm Nurse Thomas Reed, with 23 years in psychiatric care. Acute wards, forensic units, long-term facilities. You learn to read the unspoken, a patient's posture, their silence. But some cases defy explanation. Daniel, our watcher, was one such case. Admitted to our step-down unit after a failed overdose, Daniel was in his late 20s, no prior psych history. But his eyes carried a weight beyond his years. Quiet, cooperative, he took his meds, joined group therapy, yet always seemed to observe, as if tracking something we couldn't see. We placed him in room 4A, a single in our 1970s-era Midwest facility. A week in, he approached me at the nurse's station, voice low. "The man in 2B, don't leave him alone tonight." I thought he meant James, a bipolar patient with suicidal tendencies. I reassured him we did 15-minute checks. That night, at 2:07 a.m., James attempted suicide with a knotted bed sheet. We got to him in time, but his gaze never recovered its spark. Days later, Daniel told a tech, "The woman in 6C won't make it unless you move her." We just adjusted her meds. She seemed stable, even cheerful. That night, she cut her arm with a smuggled plastic shard. She survived, found only because she missed breakfast. I started a private notebook. No DSM code fit this. Daniel's warnings were calm, flat. "He's not safe. Her smile's wrong." Within 48 hours, every patient he named triggered a code. Self-harm, a fall, an attempt. He was never wrong. I consulted our psychiatrist, Dr. Ellis, Harvard-trained. She suggested Daniel was hyper-attuned to subtle cues, posture, tone, micro-expressions. It sounded plausible, but I saw it as a forecast, not data. We tightened checks based on his words, flagging charts discreetly. One night, after Daniel flagged a patient, I asked what he saw. He paused, then said, "Not behavior. A shadow, just behind them. It doesn't move right, doesn't blink with them. It stays, even when they laugh." I'd seen that patient's forced smile earlier. It didn't reach his eyes. Then one morning, Daniel skipped breakfast. I found him in his locked room, staring out the window toward the staff lot. "It's my turn," he said, eyes fixed past me. "It's been behind me 2 days." I asked what he meant. He whispered, "Some leave. Some stay. I'm a watcher now." We put him on constant observation, removed risks. I stayed late, watching him stare at the wall, unblinking. He never attempted but stopped eating, speaking, responding. We transferred him to long-term care weeks later. His last words to me, "I stay to see." Years later, his new facility reports he's mute, still watching. Sometimes they call a patient overdosed. Daniel named them the day before. I keep my notebook, not for charts, but to honor those he tried to save. Was it intuition or something darker? In psych, some things elude diagnosis, lingering at the edge of reason. I'm Dr. Rachel Nguyen, a psychiatrist with 15 years in locked wards in state hospitals. You learn to decipher silence, to read the weight behind a patient's gaze. But some cases, like Anna's, defy every clinical framework. Anna, early 30s, arrived at our Midwest facility from a rural hospital, labeled high-functioning with schizoaffective disorder. No violence, no resistance, just an eerie calm. She took her meds, lithium, risperidone, followed routines, but her presence unnerved staff. Her eyes, sharp and unblinking, seemed to study us. We placed her in room 5D, a single in our 1960s-era wing, its faded linoleum betraying age. During the day, Anna was unremarkable, but at night, her eyes changed. On 2 a.m. rounds, my flashlight caught her gaze. Pupils dilated, swallowing iris and sclera, pure black. I documented it. Pupils unresponsive to light. Labs and neurology consults were clean. No medication side effects. No brain anomalies. It happened nightly, always at 2 a.m. Then came the whispers. A tech, Mark, steady for years, came to me shaken. During rounds, Anna had whispered his sister's name, dead from a car accident a decade ago, and described her last words, private, never shared. Another nurse, Lisa, heard Anna murmur details of a miscarriage she'd kept secret. A third, James, was told, "He's still waiting for you," referencing a brother lost to overdose. Each time, Anna's delivery was calm, her black eyes locked on theirs. Security footage showed no nighttime wanderings, no access to staff files. Psychiatric evaluations revealed no delusions, no cognitive decline. Anna was lucid, almost too much so. I sat with her one night asking, "Why do your eyes change?" She turned, her gaze ink dark. "Night shows what day hides," she said. "They speak louder then, the ones who follow." My skin prickled. For months, I dreamt of a figure at my bedside, whispering my name. I told no one. I pressed her. "Who's speaking?" She smiled faintly. "The ones you carry. They're patient, but they want to be heard." I left, rattled, unable to chart it. Was it intuition? Coincidence? Her chart showed no prior behavior like this. No whispers, no patterns. Yet new staff kept quitting, spooked by her words, each tied to a buried guilt or loss. Anna was discharged abruptly, transferred to an upstate facility. The paperwork was messy, signatures unfamiliar, and the receiving clinic had no record of her. She vanished. In psych, you learn to hold space for the unexplainable. Anna's whispers weren't in the DSM, but they linger, like a shadow just out of sight.